and Professor Trost. And I think we should move to the next session. Thank you. Good luck, speakers.
So we still have 10 minutes. Noor, you want to take some questions or discuss any of the topics that were just
Still have
elaborated
time?
here?
Okay.
Yeah, we have 10 minutes.
29. Okay, sure. I think I do have a question for Adriel regarding his Moya Moya talk. He mentioned that in his study he found that patient with this specific trait has some brain atrophy. So do we know that was there any association? Was there any reason that why they had atrophy more compared to the control group? Is he still here or?
Adriel,
Sorry,
please join.
this question addressed to, sorry?
Yeah, I mean, you talked about the Moya Moya, right?
Oh, yes, I did. Yeah. So sorry, I just stepped out for a bit. I missed your question, sorry.
In one of your like I think one of your finding was that the patient with this specific gene or a specific mutation, they had more brain atrophy compared to the control group.
Yes, correct. So we so sorry. I just have a bit of technical issues at the moment with my laptop. Just give me a second.
Sure.
But we did hypothesize that it had to do possibly with the development of sort of microischemic changes, which overall might affect the overall sort of health of the brain. So because of that, we did see that likely we hypothesized that because of this, due to ischemia of the brain, there might be an earlier sign of brain atrophy in that sense. So even though that they're clinically well,
Yeah.
there is a concern that they may be more prone to getting sort of memory issues, functional issues at a much earlier stage than other sort of patients who might be non-variants. So because of that, we actually did propose to consider sort of earlier screening for such patients in terms of their memory, in terms of their functional status for them. Yeah.
Yeah, I mean the patient with Moya Moya, they're prone to have like brain atrophy. I was just wondering that why this specific gene would make it more prone to develop. Yeah.
I think we suspect because if we look at the gene itself, we did find that it has sort of pathophysiological roles in angiogenesis as well as vascular remodeling and immune regulation. So I think it's all in because of problems with the perfusion at maybe the microvascular level, and because of that, such patients will then be more sort of vulnerable to getting brain atrophy. Yeah.
Yeah. And then there is another question from Ocean if she's around. Ocean, are you here? Or I think she's not. Yeah, just like I mean, she talked about the role of steroid in prevention of recurrence of chronic subdural. It was a prospective study. So just a question that do you know that how much dose did you give? Maybe I missed that part in your talk. I think she's not here.
She's here. I've just asked her to unmute.
Oh, can you unmute yourself, Ocean?
She's unmuted.
Okay. So the question is like, you talked about the role of steroid in prevention of recurrent subdurals. Can you talk about the dose, that how much dose did you give, and and have you seen any complications? I don't know, where is she? Oh no. Well,
Ocean, can you please reply to this? Maybe switch on your video if you can. She's co-host, so she should be able to do it.
yeah.
I don't think so. I don't know.
Well,
Sandeep, what dose would you give steroids?
Yeah, I will not say, I wanted to say that 19% recurrence is way too high. I think there has to be something with the technique, and just using steroid, and even with steroid, it was 9% recurrence. I think we must have done more than 200 and in last 10 years, 7, 8 years, but I don't remember a single recurrence. So I really don't know what is. So people talk about middle meningeal artery embolization also. So in last 1 month, I have seen 2 patients getting a recurrence after getting a minimal MMA embolization elsewhere. So I don't think any of these things are perfect.
Agree.
So, Dr. Sandeep, do you remove the inner membrane as well when you're doing the
Yes.
conic subdural?
So
Because
so we
historically,
published our paper in
historically,
World
what we've been
Neurosurgery. No, we published a paper in World Neurosurgery a few years ago. So we use endoscope in all these patients, and there is invariably there is always a membrane. And with the endoscope, it is very easy to remove the membrane. So we make a mini craniotomy and then remove the membrane with that.
And do you keep
and
a
by
date?
mini craniotomy, you mean about 2 by 2 or 3 by 3
Yeah,
centimeter?
2 by 2. Actually, it's probably 2 by 2 or less than that.
Okay.
And we leave a drain for a day.
Okay. And then what are your thoughts on double burr hole rather than doing a mini cranie? I'm not sure because I've seen people doing 2 burr holes and their results are really excellent. One of the paper from Mayo that I recently read that they also have said that the recurrence rate is really close to I would say 0. I mean, it was
So
maybe they had only one case in a couple of years.
I think if your technique is good, recurrence rates will be low. We used to, like traditionally, 2 burrow technique has been done. So throughout my career, I used to do 2 burrows. But with that, it's difficult to remove the membrane. So in certain patients where there is a recurrence and you have to remove a membrane, you have to convert into a craniotomy. So now routinely we do a mini craniotomy, and with endoscope we remove the membrane.
Yeah, I mean, you are so right about that MMA angioembolization, and now they're saying that because of the cross supply from the opposite side, so now there are some recommendations that they should do bilateral. So it's too
There's
much.
no end to it.
Yeah. Well, is there any question from any of the audience or speakers? Because I don't see anything in the chat.
Maybe we ask Greg this question, who has not done one of these for decades.
Subdurals?
Yeah,
No, I did trauma call up until about 6 or 7 years ago.
really.
And in my training, I always did 2 burr holes and flushed them out. And I can't remember, maybe it's just my memory, but I have not had a recurrence. I've always been happy with 2 burr holes, but I would say that maybe the issue is that the subdurals that are chronic in other countries may not be picked up as soon as they are here in the United States. And so that may be why Sandeep maybe thinks there's membranes in all of them and they have to be removed, but that hasn't been my experience.
Okay, Omar Farouk wants to say something. Omar, you can unmute. I will
Umar.
just... Yes, Omar, go on.
Can you guys see me? Hi, hi, Greg. How you doing? The beard looks nice.
Good, my friend.
I'm digging it. Yeah, I had I think there was a trial, Dex CSDH, as far as I remember, and I thought Dex was out after that because what I remember was there was like 16% serious adverse effects with Dex compared to 7% or something. I mean, I can check that, but I think Dex was out, and in UK, we're not using Dex in chronic subdurals anymore.
That's true. I don't use either, and I'm not sure, Dr. Greg. Do you use sub?
No,
Yeah,
no.
right?
Never have.
So
No,
I also
30 years
don't
of
use
doing
it.
this.
I use it in only one patient, and because I can't remember what the issue was, he had just underwent a cardiac surgery and he had a subdural hematoma, and for some reason he could not undergo surgery. We gave dexamethasone and his subdural disappeared. It might have been a coincidence also, but that was only one patient's experience.
But I will say too that the literature is really beginning to support middle meningeal artery embolization. So that may be the future.
Yeah, I mean, with MMA, the earlier results were not, they were not that concise, but the latest ones, and they are coming quite a bit now because the radiologists, they are taking up on it, and in a lot of centers over here now, radiologists are pretty keen to do that, but and their recurrence rate is quite low as compared to surgery. But standard over here in England, we're still using drain. Drain works. But one thing that has changed over here in practice in most of the centers, that we're not using subdural drains anymore. We use subgaleal drains, and they have less, penetrating the brain, kind of all sorts of those shite. Okay, that's not there anymore, and it works perfectly because you just place the drains subgaleally on top of the hole, and then you just leave it for 24 hours. We're not leaving them for 48 hours like we used to, and nobody is doing those all of those things, keep the patient flat bed rest and this and that. That has all gone here in England. That's the practice I've been seeing here, to be honest.
Yep. Harshad Parekh from India just said that he's done 500 of these with doing a small craniotomy. And so there are all ways of doing it, and he has had no recurrence. So I think everybody is, as long as you do a good job, it's okay. Do you want to?
No one has zero recurrence. I mean, if someone says
agree.
zero of something, they're lying.
Yeah, Sandeep, you're lying. Sorry.
Pardon?
Greg just said you're lying if you're saying you have no recurrence.
Yeah, if they had a recurrence, if they had gone to another hospital, I don't know,
Yeah,
but
I
I don't
think so.
recall anybody whom we had operated again.
Yeah.
Okay, fine. Do you guys want to wrap up and then we move on?
Yes, I think we just conclude this session, and thank you very much for all the speakers. It's been like a joy to learn from you guys too. And thank you, Dr. Sharif, and thank you, my co-moderator, for giving us this opportunity.
Thank you.
Greg, you're the moderator for this
Okay.
session.
Is Dr. Qureshi on?
I don't think he's joined. So Francisco,
Alrighty,
do you want to help him? Yeah,
No, I
Sandeep or
can do this. This is
Francisco.
not
Okay, all right.
some big challenge.
The
So we're
other
going to
thing
do a
is,
controversy session
yeah.
now, and there's 7
Make-
topics that are picked.
Yeah.
The speakers each get 6 minutes apiece, and I'm sure that Imad will let them know when their time is up. There's been a change in the ordering. The first one will be spine monitoring versus no monitoring with Mirza, and I'm sorry about pronouncing your last name, Pojskic versus Mehmet Zileli. And I think we'll just present in the order that the speakers are listed. So Mirza, you are up first. Please stick to your time.
Yes. Hello, everyone. Can everybody hear me?
Yes.
Okay, thank you for the kind invitation. I'll just share my presentation.
How do you pronounce your last name?
Pojskic.
Pojskic. Yeah, no chance I'm getting it, man.
Don't worry, I have a list of wrongly pronounced versions of my surname. Okay, so thank you for the kind invitation to webinar with many of my friends, mentors, and teachers from WFNS. Without further ado, I will start with controversies in spine surgery, the critical role of neuromonitoring in spine surgery to improve safety and outcomes. A subject which is near to me, since at the department where I work, I am one of the people who's responsible for the neuromonitoring. That's also a hot topic in Germany and European neurosurgery. Who is doing the neuromonitoring? You have departments where you have neurologists and specialized technicians who do that, which is, in my opinion, also the best way to do it. And you also have departments where neurosurgeons are doing it, neurosurgical residents and neurosurgeons. So I will try briefly to define neuromonitoring, to understand its primary goals, explore its multimodal technique, review the evidence in favor of its routine use, address common counter-arguments, and to provide key takeaways. So what is it? It's actually the real-time assessment of the functional integrity of neural pathways, sensory, motor, and nerves during surgery. It provides actually a continuous neurological exam on an anesthetized patient, and the goal is to provide the surgical team with immediate feedback to prevent iatrogenic or surgery-induced nerve injury. So it detects insults early. It can detect changes, for example, from compression, stretch, or ischemia before they become permanent. So if you're resecting an intramedullary tumor or placing a pedicle screw which landed in the area where you don't want it to land and it caused compression, you can see on the monitoring the beginning of the compression while you insert the pedicle screw, and you can see the very early changes due to ischemia if you have a dissection of the intramedullary tumor in a way which is not good for the patient and for its anatomy. It allows for intervention. You can respond to an alert by correcting the cause, releasing retraction, removing an implant, adjusting a screw, or correcting hypotension. And there is the reversible insult concept. This is the core value proposition and catching a problem in time, which makes it reversible. So this is a scheme of what you can monitor in spine surgery. Neuromonitoring is very big and hot topic in skull-based surgery for monitoring of the cranial nerves, or for brainstem surgery. In the context of spine surgery, we usually monitor motor pathways using transcranial electrical stimulation of the motor cortex for MEPs, or motor evoked potentials, epidural recordings using D-wave, and muscle recordings. Motor evoked potential, you can monitor directly the certain muscles, direct EMG, and somatosensory evoked potential. No single technique is perfect, and you need to use the multiple methods which cover all the possible pathways. SSEP, somatosensory evoked potentials, which monitors the dorsal columns. Sensory pathways for touch, vibration, and proprioception. MEP, motor evoked potential, which monitors the corticospinal tract, and this is often considered the most critical for preventing paralysis. EMG, electromyography, is free-run EMG, which detects irritations to the nerve roots, and triggered EMG to test pedicle screw placements. You have DNEP and D-wave, which is direct and a real-time assessment of the functional integrity of the corticospinal tract within the spinal cord. There is an old paper from 2007 from the very famous Francesco Sala and Martin Suter group, which has shown that the correction of the patients which profit the most from the intraoperative neuromonitoring. Correction of spinal deformities with scoliosis greater than 45 degrees, correction of congenital spine anomalies, intramedullary and extramedullary tumors, and extensive anterior and posterior decompression in spinal stenosis in spine causing myelopathy and functional disturbance of cauda equina or individual nerve roots. So neuromonitoring is really not needed in every spine surgery. It is not needed for ACDF. It is not needed for simple lumbar discectomy. It is probably not needed for simple T-lifts or simple surgery, but in high-risk patients, and this is what also the guidelines show, is the use of neuromonitoring indispensable. And many scoliosis surgeons would say that it was a major game changer, which enabled them to safely correct or to achieve bigger degrees of correction without fear that the patient is going to be neurologically compromised because they had the neuromonitoring the whole day. This is one of the example how it looks, just for our youngers to see normal and altered motor evoked potentials. This is a great paper on spine deformity, intraoperative neuromonitoring. You can download online and see the most common curves and the most common differences in the neuromonitoring for neuromonitors to see. So it is not all some lines which nobody understands, but you also have a trunkload of scientific literature which have placed a very specific parameters of changes in the waves, which can explain you when is which change relevant and when it says that the patient is going to have a deficit. So the fundamental role of the D wave, if this is with MEP, is most important to detect motor deficit, is to distinguish between a transient loss of signal due to surgical irritation and permanent catastrophic injury to the spinal cord. So you have 50% rule, well-established and crucial prognostic guideline. If the D wave amplitude drops by less than 50% and muscle MEPs are lost, the injury is likely to the gray matter of spinal interneurons. This is a transient injury. So the patient will likely experience a temporary motor deficit, but is expected to make a full recovery. And if the D wave amplitude drops by more than 50%, it indicates a significant loss of white matter tracts, which is a sign of a severe and likely permanent injury, which alerts the surgeon to immediately take corrective action.
You should move to your conclusions since your time is up.
Okay. There are checklists to the response for intraoperative neuromonitoring in stabilized and in destabilized spine. These are the guidelines which advise use of neuromonitoring in highly selected cases. It, like I said, allows for more aggressive correction in complex deformities. It improves patient outcomes by reducing rate of neurological deficits. It is standard of care in many regions of the world. If you operate on a patient without monitoring and he has a deficit, you have a big legal problem afterwards. It is cost effective by reducing the deficits, and it also gets reimbursed. It has some counter argument says that it has too many false positive, which is causing an unnecessary alarm. False positive is actually a temporary inconvenience, and false negative would be a catastrophic life-altering event. And also some say that method is more predictive of short-term rather than long-term neurological deficits, because it tells you, it warns you that the deficit is going to be like graver than it is in the long term, which in counter effect leads that you resect less of the tumor or that you achieve less of the correction of scoliosis. But actually the large studies on use of monitoring have shown that this is not true.
We should stop there out of fairness to your...
for preventing devastating injuries. And thank you. These will be the
Thanks, Dr. Pojskic. There will be a poll sent out at the end of the session so that people can vote by cell phone. Although I'm sure everybody has their own opinions about these things. The next speaker will be Mehmet Zileli, who must be talking about no monitoring.
Hi.
Hi, Mehmet.
I'm very happy to be with you in this meeting. Do you see my screen?
We see you.
Only me?
Mehmet, you need to make a very strong case for those of the rest of the world where there is no possibility of monitoring. You've got to make a strong case so that we don't
call
feel
that bias, Moody.
and we don't feel pushed into getting monitoring.
Exactly.
So go for it, Mehmet.
Yeah.
We all will vote against it. Don't worry.
Yeah, good. This is my slides.
Yes.
I will say no for monitoring. It doesn't prevent neurologic complications as we are expecting. And first of all, we must know that there are many cases going on. Actually, the number of monitoring cases are increasing from this 300% increase in the United States. Does it prevent neurologic complications? If you look at the types of monitoring, although Mirza has already mentioned, but types of spinal cord lesions are very important. Mainly, there are two types of ischemic. There are two types of lesion: ischemic or mechanic. If it is ischemic, the response to treatment is good, and over-distraction, hypotension, these are some reasons. And it is slow, and then a response is very nice. But if it is a mechanical lesion, like you are cutting the spinal cord during surgery, what can be done? Does the monitoring prevent it? No, you cannot. One of the main issues is that the monitoring types, whether it is very slow, fast or very fast. You cannot get a good response with SEPs than EMG or MEP. The duration, as I said before, if it is very short, monitoring is useless. If it is after certain time, warning of surgeon is possible, or anesthesis is possible, and then you can get benefit of a monitoring. After a long period, like after surgery, you cannot avoid it too much. First of all, we must use such measures. If blood pressure low, elevated, overbleeding, hemoglobin must be replaced. For the implants, remove destructive instruments, make a radiology control, ensure for implants do not compress the dura, and possibly somebody do that, IV bolus methylprednisolone or wake-up test may be possible. What about the limits of monitoring? There are many limits. Actually, there is a secure zone of sensitivity. Otherwise, there are false negative and false positive responses. If it's very sensitive, there are false positive responses, then it prevents you to make your surgery. Likewise, you are removing a tumor, and then it tells you you are making a hazard to spinal cord. If it is false negative, it's worse than this, because then you are having a feeling of security, but the result is bad. Another thing is the SEP or MEP. SEP is not very important because it is the reflection of the dorsal columns. However, MEP is important because we are more for motor function. These are the scenarios, what happens during surgery. If you look at the consequences of these scenarios, if there is no change in potentials and post-op no deficit, this is true negativity. And if there is an incidence like worsened potentials and there is a post-op deficit, this is also true positivity. But in both of these instances, we don't have any benefit from monitoring, because these are the results only showing what happened during surgery. What about this? Potentials worsen, but there is no deficit, like false positive. This causes you do an improper surgery and causes an anxiety for surgeon. What about this? False negativity. There is no incidence during surgery reflected to the waves, but there is a post-op deficit. Worse monitoring. Surgeon will have a wrong safety feeling. The best one is this, probably. There happens some potential worsening, and you are having some measures against this, surgical or anesthetic measures, and potentials improve, and there is no deficits. But how often does it happen? If this is not happening, monitoring is useless. What about the evidence from the literature? This about the spinal cord tumors, most of them are intramedullary tumors. There are also some intradural tumors. There are 109 patients. Monitoring has not improved damage to spinal cord as a result of this study. There are 1 false positive. There are 24 true positive. But the intraoperative measures did not prevent those neurologic deficits. What about deformity surgery? Yes, is a very common usage, as you know. Intraoperative incidence is 1 out of 42 surgery. Permanent deficit, 1 out of 573 surgery. I can skip some slides. From that spinal deformity surgery results, 1% neurologic deficits, 5% alarm incidence, and false positivity is 2.5%. It's very high, actually. They prevent you do a proper deformity surgery. And the alarms are mostly related to the anesthesia, more than 50%. There are case reports in past negativity with paraplegia after surgery, although the monitoring had no incidence. I will not mention much. Another issue is that preoperative neurologic deficits, if there is severe paraplegia, paralysis, those patients cannot be monitored. You cannot make it. What cases are useful? Deformity surgery, especially cases with severe correction and osteotomies, and intramedullary tumor surgery. And it has a limited value in cases with neurologic deficits. This is the fact.
So
EMG monitoring in
you should move to your
posterior
conclusion.
insertion is unnecessary. And monitoring in ACDF surgery is unnecessary. Monitoring in CSM surgery, cervical spondylotic myelopathy, is unnecessary. And I will come to the conclusion slide.
Thanks.
This editorial from Neurosurgical Focus in 2017 is saying that it is still not a treatment standard, and not monitoring cannot be accepted as a malpractice. Monitoring can be valuable in neurological high-risk spinal cord patients, but has limits. Maybe we can say in certain conditions, yes, but it has significant limits. It must have indications, and it must be done in good hands. We are sometimes overusing something, like we are doing in each low back patient MR images. It is like this. Thank you for listening to me.
Thanks, Mehmet. There'll be a poll that'll be sent out, I think, through email, and people can vote. I think this is a topic that you could spend 45 minutes apiece talking about. So, unfortunately, I feel sad for both of you, since you didn't have really the time to go through everything you needed to. Moody, we're going to move back to the top of the list, I think.
All right.
All righty. So that the next one is going to be MIS